Welcome to the ADAA discussion on innovations in digital mental health. My name is Sasha Sicard, and I am the Associate Director of Education and Membership Engagement here at ADAA. We are so delighted to have Dr. Emily Bernstein and Dr. Nick Jacobson here with us today. Dr. Emily Bernstein is a clinical psychologist and investigator at the Massachusetts General Hospital and Harvard Medical School. She studies alternative and scalable interventions for mood and anxiety disorders, including using smartphones and physical activity to increase the impact and accessibility of treatment. Dr. Nick Jacobson is an assistant professor in the departments of biomedical data science, psychiatry, and computer science within the Center for Technology and Behavioral Health in the Geisel School of Medicine at Dartmouth College. Dr. Nick Jacobson is an assistant professor in the departments of biomedical data science, psychiatry, and computer sciences within the Center for Technology and Behavioral Health in the Geisel School of Medicine at Dartmouth College. He directs the AI in mental health, innovation and technology guided healthcare. He has a strong interest in creating personalized, just-in-time, adaptive interventions and the quantitative tools that make this work possible. So let's get right to it. If we are using an app, what does it mean for that app-based therapy to be guided versus not guided?
What does it mean for an app-based therapy to not be guided? When it's not guided, it's sort of like a self-help book where you would download an app and go through the treatment from start to finish on your own. What it means for an app-based therapy to be guided is a little more complicated. Most basically, it means that there's a live person involved in some way trying to help you work through therapy and see better outcomes. Our research has been focused on trying to understand what that actually looks like. Because guides can take a lot of different forms. So a guide could be someone on the app staff just sending you messages occasionally saying you're doing great, keep going, trying to just encourage you. But it can also be the other end of the spectrum where you have a therapist meeting with you regularly, going over content, helping you adapt what you're doing to best fit your symptoms, and really being there with you every step of the way. So in our work, we were trying to understand what does this look like in research studies, but also out in the real world so we can understand best practices. Because right now it seems like the field doesn't actually know what the best way is to guide folks through app-based therapy.
I think I guess in terms of the future of this field, there's a lot of work going into what types of support we actually need to actually have effective outcomes and what fundamentally can scale to large numbers of people, because the background of why digital mental health is so important is access is so difficult. So thinking about the infrastructure for supporting that, guides, the level of expertise that guides have and require. So if you have a doctoral level clinician that is your guide, the model needs to fundamentally change in terms of access to it, because there are only a certain number of providers that can actually provide care. So the level of support and the level of training that guides have, as well as whether guides are needed, is an area that is continually evolving within the field.
And that's really the crux of the question here, which is, I think, intuitively, we all believe that guides would be helpful, right? Mm-hmm. Having a cheerleader, having a therapist there, it seems like that would really make a huge difference. But the truth is we don't actually know. There's some studies showing that having a therapist versus a non-professional cheer you on doesn't really make a difference who the person is. And it's also not clear that with a good app, you really need all that much support. And so we think that we need a lot more research into this to figure out how to really optimize our use of people in these roles, because as Dr. Jacobson was saying, it's really a question of scalability, that people's time is limited and it's also expensive. And so we don't want to be spending a lot of valuable therapist time supporting app-based treatment if it won't actually make a huge difference. And so we want to understand for what types of apps, what types of populations, what types of therapies, and even when during therapy, having a therapist or any kind of guide makes the biggest difference.
That is a great question, and I look forward to the answer. So why do you think we really need to study this specific part of digital healthcare, and what has your research shown so far?
I think we need to study it for two reasons. The one kind of closest to all of our hearts is wanting to make these treatments the best they can be for our patients. And so we want to figure out what kind of support actually does that. And so in a lot of ways, digital therapy is pretty young. Mm-hmm. And so it's an open question that we need to figure out so that we can most quickly and best help people out there. The second reason is more practical, in that, as I said, human time is expensive, and the number of people out there who are trained to do this work is really limited. And so if the promise of all of these apps is that we can scale, that we could easily provide apps to hundreds, thousands, millions of people, that's not really true if you need a therapist involved, because there aren't enough therapists to serve millions of new clients. Mm-hmm. And so practically, we need to figure out how to best use human time for the people and the treatments who need it most. In terms of what we've found so far, what we've found is that it's kind of an open question. There really isn't enough data right now to guide us. And so what we think is most important for the field moving forward is to start asking this question more actively. Right now, a lot of the research has been focused on the apps themselves, which is obviously important, but the examination of the people side has been much less than sort of an afterthought. So we really think there needs to be a push to better measure what people are doing, how much time they're spending helping patients, and to actually look at it analytically and therefore make decisions about how they deploy their staff in a more data-driven way.
Wonderful. So the app would kind of serve as a personalized medicine. Someone is able to kind of tap onto their phone and find the healthcare that they need. What do we think personalized medicine really means?
So that's a big, broad question that the field has very different perspectives on. Personalization can come in many different forms. When you would sit down with a therapist or provider, and in many ways that they are personalizing it truly to the client. So they talk differently based on what a person's background or experience is, and the conversation evolves to tailor to that individual's background. So in a lot of ways, humans actually provide personalization in an ongoing way. Mimicking that in an app-based setting with a human can involve a similar process when it's not prescripted. A lot of applications and human contact in applications can, for convenience's sake, to try to save their time, involve things that are often scripted ahead of time and essentially copy and pasted, or they click a button to have this in a portal if it's like some kind of contact that is not actually like live voice-based or video-based conferencing. So one of the ways that we're trying to work within personalization is within some advances related to deep learning and artificial intelligence, where we are actually having a lot of these kind of conversations be generated via these models, these large linguistic models that can actually change much like a human could and adapt to the context. There's a lot of different elements of personalization, though. So when we think about personalization, one of the ways that the field tends to think about it in medicine is you take a big, broad data set and you try to analyze that and look at different individual level characteristics. So people say different gender backgrounds, different races or ethnicities, different psychological or psychiatric issues, and trying to see which kind of elements might benefit whom. There's another level of personalization that kind of, instead of going from the top down, you go from the bottom up, and you work specifically and try to tailor assessments and treatments to an individual by seeing what actually works for that individual, both in trying to predict like what their symptoms are on an individual basis, and like really trying to model that unique person. So rather than going big, broad, going very specific and focused and tailoring to that person. We're doing both sides of those things, but and I think they both have pros and cons and different kind of problems associated with them. But in a lot of ways, I'm really excited about actually starting with the individual, because you can provide a lot of granularity and things that humans are very idiosyncratic. So trying to assume that this one size fits all, even when we think about different divisions of psychotherapy or different divisions of care that could be offered, it's not as straightforward, and the heterogeneity that exists among people can really get in the way. So a lot of what is called idiographic approaches can really try to address that.
Yeah, it seems like there's a lot of great things that are coming in the future as we continue to research it. For someone who is looking at app-based therapy as it exists now, what should they be considering, and what should they be looking for?
Probably, I guess for the average consumer, one of the things that is really challenging is trying to find evidence-based care. A lot of the applications in the market have not been evaluated. So the vast majority of applications that are on the market today have not been evaluated in a scientific way. Many of these applications aren't designed with psychologists or psychiatrists in the process. So it could be a computer scientist that thinks that something should be done in a certain way based on their own personal experiences. And there is some real danger to the implementation of this. So I think from the average consumer model, there are platforms available to try to actually address this. So CyberGuide is one of them. It's a nonprofit that tries to evaluate the evidence base for applications and tries to present that back to consumers. There's a similar initiative by the American Psychiatric Association to try to evaluate and recommend apps. These are really important platforms for the average consumer in evaluating what works for whom, and if there is actually enough of an evidence base for someone to want to use this, because not all applications are helpful and some are actually harmful.
Great. And do we have any key takeaways that we want to give to our listeners today?
I just say I think this is a really exciting space to be in with a lot of great people working on it. So I think, like Dr. Jacobson said, there's a lot out there that's really great. There's also, unfortunately, a lot out there that isn't. And so I hope people are willing to try out some of these platforms, especially the ones that have a research base behind them. And also try not to be disheartened if not everything that you try first seems to be the most helpful. Every day, new technologies are coming out, new iterations of some of the first apps are getting deployed. So keep up with the work we're all doing. We're working really hard to get apps out there so that more people can have access to really high quality evidence-based treatment.
Perfect. Thank you both so much for joining me today and sharing your research. Have a wonderful day, and thank you to our listeners.